start?
Yeah, he's in Melbourne.
Welcome everybody.
Yeah.
Thank you for coming, everyone, after I'm sure a very, very busy day, start to the week. Thank you so much, Dr. Ramon for giving this presentation to us tonight. So this group is Adelaide Airway Interest Group. So basically anything that is to do with airway health and sleep, and how many professions basically play a role in this whole picture. So what my aim is how we can basically bring everyone together so we're not practicing in silos, and how we can eventually move this conversation towards a more holistic kind of a situation, rather than footballing people from one place to another and care being more fragmented. My interest is in prevention of this issue, and how we can grow our children, young ones, in the right direction so they don't get to that point. As you know, the gold standard for treatment of obstructive sleep apnea is a CPAP machine, which in my opinion is a bit of a life sentence, and again, I don't wish it upon anybody. So sometimes if people don't want to do that, then they go to someone like Ramon, and he does some surgery to alleviate the issue. But again, you know, how can we even prevent that? It will be a great insight to see what this surgery looks like and what it's involved, for all of us to learn a bit more about that. And hopefully we can again continue that discussion as to, you know, what are some of the things that we can do to prevent these kind of situations. Before we start, I acknowledge that we do meet on the land of the Ghana people, which has given me freedom and safety for the last 28 years. As you know, I've come from Iran, and I'm looking at a horizon that looks a little bit bright at the moment, despite all the bloodshed and hurt that is going on there. But hopefully the dawn will break soon. So let's keep the fingers crossed there, and I hand it to
Thanks so much.
Do we need to pull the curtain if they're gory pictures?
Oh, that's not a bad idea, actually. Yes.
Because the public is walking past.
You need to see.
Yeah. Thank you so much, Roshanak, for a very kind introduction, and also for kindly inviting me to speak on this topic. So I understand what everyone's perspective is. I know Amelia and Flora, but I don't know anyone else. So if you could just sort of help me figure out what everyone's
Yes, absolutely.
clinical perspective is, etc.
Sure. Shall we just go around and
Sure.
do
Thank
that?
you. Sorry.
I can start if you want, just so that everyone else knows. I think I'm Amelia, I'm a paediatric dentist, so I've been here since inception of the group. Thank you to Roche. So I work a little bit at Women's and Children's, and a little bit at the Adelaide Dental Hospital as well.
Well, dentists that have been out of practice for a while and hoping to regain practice re-entry. But I have also really a strong interest in collaborative, multidisciplinary sort of approach to patients' healthcare.
Awesome.
Yeah.
Yeah. You've heard us, I'm a respiratory physician
All right. Okay.
and prescribe CPAP. But I've been to a Maxillofacial surgical conference with Stanley Liu as the speaker.
Yes.
That's why I pulled the curtain, because the pictures were very
Yeah.
sharp. I still got them on my
Good
phone.
Yeah.
But I'm very interested in
Sure. Okay.
in
I wonder. I don't think it's going to compare with Stanley's volume of work, but hopefully enlightening for everyone to some degree.
Well, I'm a researcher in the academic in the medical school.
All right.
I
Okay.
supervise a couple of facial as trainees, registrars.
Right. Okay.
But my area of other research is being a researcher and living on grants and projects. I've done as diverse research from reproductive medicine to sarcopenia.
Right. Okay. All right. Okay.
I'm Zalmi, I'm a general dentist with special interest in patient with sleep apnea, and provide them with mandatory.
Right. Okay. Awesome. Yeah. It's good for me to know all this stuff because I don't know easily.
I'm Ken. I'm a physio and orofacialologist with a particular interest in high performance and longevity.
Right. Awesome.
Hi everyone, I'm Victoria, I'm a speech pathologist. I've also done some work with orofacial over the years, worked with a large paediatric client base and
Right.
worked closely with Roche.
I'm Diane. I am a general dentist and run a private dental practice in Prospect. We have a very large children-based practice, but family practice, and I actively refer patients to ENT, young children for obstructive sleep apnea, as well as getting patients away from CPAP machines, and it's life-changing for them as well, and then stepping in with mandibular advancement appliances. So I was introduced to it by actually an IHT that came into the practice with a particular interest. She's sent her apologies. She's actually an Olympic ice hockey umpire for men's ice hockey, so she's just come back from overseas.
Right.
But yeah, we did in conjunction with one of the other dentists, the orofacial myology course last year, and we just want to, like you, Flora, provide holistic care and be proactive rather than reactive at the end stage of damage.
Okay. Thanks.
I'm Alicia. I work here at Adelaide Cosmetic Dentistry doing orofacial myology. So I work alongside Roche, helping her with pre and post-op care for the patients that she does tongue tie release.
Awesome. Okay, great. Thanks.
My name's Tess. I'm an oral therapist, still working in dental practice in Goulburn, and I also have my own myofascial therapy clinic.
Right.
In Adelaide, I've got a special interest in particularly TND,
Right.
facial pain in terms of more myofascial pain patients, and applying techniques to rehabilitate the whole area. So I see a lot of adults post-surgery, and I also have a large proportion of kids that I see post-ENT surgery, just to restore nasal breathing as primary issue, and also work with integrated breathing therapies to try and get people either more comfortable on CPAP and in some cases really try and reduce whether they need it.
Awesome. Okay, so it's a really broad spectrum. Okay, so I will try to. Some of this content is going to be pretty high level, and some of it's going to be much more basic. And so, if you don't understand something, you can jump in and ask questions. That's fine. Hopefully, it sort of covers a spectrum of things. So, a bit about myself. That's my practice just up the road in the old Abbey Hall. So, I am a specialist oral and maxillofacial surgeon, and I did most of my training in WA and some training in Melbourne, and then my subspecialty interest is cosmetic surgery. So I've done, my fellowship study was in London and Korea, particularly in looking at rhinoplasty and other cosmetic surgical procedures. So the scope of my practice, I do all general oral and maxillofacial surgery, but with a specific interest in orthognathic surgery and cosmetic surgery. I don't treat cancer, but I get the ball rolling and diagnosis and screening, all those sorts of things. So, thinking about the scope for surgical treatment of OSM, because it's such a huge topic and there are so many interventions and there are so many different elements to it, I have tried to restrict myself purely to the surgical aspects. And there's a lot of surgical aspects, right? So it's not just what I do, but there's also the septoplasty, turbinoplasty, the UPPP, base of tongue reduction, hypoglossal nerve stimulators, many different things, okay? Some things are more in favor or out of favor, they can change over time. And the ultimate procedure, which is the tracheostomy, but obviously not a very acceptable procedure for most people. So In terms of surgery, what I'm going to restrict my focus on today is really just these three procedures, the skeletal procedures for treatment of obstructive sleep apnea. Now let's just get some of our terminology correct. So orthognathic versus telegnathic. Ortho comes from the Greek meaning straight and gnathos meaning jaws. So orthognathic, like orthopedic, is for straight jaws. We're trying to achieve the normal, proportionate, balanced anatomy. Tele, meaning at a distance, means that we are no longer really trying to achieve normal balance. We are actually trying deliberately to enlarge the jaws. And so when you think about orthognathic surgery, we're much more concerned about the FAB concept. So we're trying to achieve harmonious face, airway, and bite. So the bite has to be normal or idealized as much as possible. The facial proportions have to be normal, and the airway has to be normal or as close to it as we can. But with telegnathic surgery, that priority matrix is upended, and we will push airway to number one and sacrifice to a large extent face. So the facial proportions will no longer look normal after after skeletal surgery for obstructive sleep apnea, because only one thing can be number one, and so we have to pick that. But we don't have to have a poor bite at the same time. So normally we'll have a good airway and a good bite, but we might not necessarily have ideal face. So when we're thinking about obstructive sleep apnea surgery, we're trying to target sites of obstruction, and so there's several regions of obstruction. So we can have nasal cavity obstruction, we can have retropalatal obstruction, retroglossal and hypoglossal obstruction. And in some cases, it may be just at a single level, but the truth is most patients presenting with clinically significant sleep apnea will have obstruction at multiple levels. And so usually a single surgical intervention is not really going to be, or traditionally hasn't been considered to be that effective. So someone who would get perhaps a U-P procedure might only get partial improvement because there was no addressing of a bulky tongue. So even if they had that plus radiofrequency ablation of the base of the tongue, maybe there's another spot, lateral pharynx, where there's some obstruction perhaps as well. So it's difficult in these multi-level obstruction, and they represent a major fraction of the cases. So we're going to start first of all about maxillomandibular advancement as the key workhorse procedure for obstructive sleep apnea. And how does it work? Well, basically, it's acting on the nasal cavity, because when you move the maxilla and you've cut through all the bony walls, you actually create quite a lot of space, and also you shorten the distance from the nasal aperture to the posterior nasal spine, which shortens the length of the passage from the inlet of air to where it reaches the pharynx. And so shortening that reduces the total length of the airway, and it therefore reduces the total resistance. And so you get less loss of air pressure during inspiration, and so you get less propensity for collapse. It also tensions the soft palate and the levator veli palatini and tensor veli palatini, even though not directly, but by tensioning that, it makes them less prone to collapsing during inspiration and inspiratory effort into the pharynx. It also tensions the superior constrictor, and it also advances the tongue base. So here's a sort of a detailed view in the sort of nasopharynx and oropharynx region. And you can see where, if you had a lax soft tissue, then that superior constrictor and the uvula and soft palate can just easily collapse and obstruct each other. So by moving the maxilla forward, we're not directly moving it because the cut is, I'll see if you can see my pointer, the cut sort of stops here at the pterygomaxillary fissure, but the soft tissue connects. So the soft tissue is pulled forward and this is pulled forward with it, and so it just tensions the whole superior constrictor, tensions the soft palate, tensions all the associated soft tissue. I'm going to show the next slide. This is a slide of demonstrating how the surgery